Hello, and welcome everyone to day 2 of the World Hepatitis Summit. We had a really outstanding day yesterday with lots of great presentations and some really great different speakers, all the way from former heads of state to civil society and people with lived experience. So it was a terrific day. And so going strongly into day 2. In day 2, in the plenary sessions, we're really looking at the kind of issues that were explored yesterday around the importance for hepatitis to have an integrated approach and the importance of a person-centered approach to health generally, and how hepatitis fits into things like universal health coverage and primary care, and really looking at, we kind of talked yesterday around financing and the challenges that hepatitis has in terms of funding, but through partnerships and collaborations we can really leverage resources that are already existing within health systems to really make a difference. So to do that, we've assembled a fantastic panel, and it's always a good secret to be a good moderator is to have a fantastic panel in front of you, because that makes your job a lot easier. So I'm just going to do a quick round of introductions first, and then we'll start with some opening statements. So online we have Dorothy Mbori Nagacha from UNICEF. Dorothy, nice to see you. Thanks for joining from New York. From the Ministry of Health in Argentina, we have Dr. Juan Castelli. Hello, Dr. Castelli. Brilliant, thank you very much. And to my left, we Juan Huat from the Center for Supporting Community Development Initiatives in Vietnam. Love to see you, Juan. And on my right, we have Javier Horcad Balok, who's the Communities Delegation Board Member to the Global Fund and the CBO rep for UHC 2030 Steering Committee, also from Argentina. And then next to him, we have Luis Mandau from GATT, Portugal, and Luis is also the co-chair of the Achieve Coalition, which is a multi-stakeholder group working towards hepatitis elimination in Europe. And last and certainly not least, we have Dr. Carrie Adams from the Union for International Cancer Control, based here in Geneva. So that's our panel. So I think we'll start with Dorothy. So Dorothy, maybe you could just tell us a bit about just kind of UNICEF in general, because sometimes we're not lucky enough to have UNICEF at our meetings. So it'd be great to hear just kind of the work of UNICEF in general, and then especially relating to maternal and child health, and really how prevention of mother-child transmission for hepatitis, sort of the synergies between those sorts of things. So Dorothy, please. Dorothy, just hold on 1 second. I think we have a sound problem.
I hope you can hear me now.
We can hear you now. Lovely,
okay.
Thank you.
I was just saying how excited we are to be at the summit this year. UNICEF typically hasn't been part of the hepatitis summit, so much as you don't know much about what we do, we're also learning a lot about what you do, and we're excited that there's a lot of interface between our two streams of work. I work with UNICEF for the HIV section and in the health section, focusing on mother-to-child transmission, prevention of mother-to-child transmission. And but in our broader child health space, I must say that your theme of a systems-wide approach really resonates with us. Because we believe that unless we take a systems approach, we're not really going to be able to deliver maternal child health services to the populations that we serve. Now, typically, when people talk about maternal child health services, we focus a lot on the challenges that we face, the issues around poor facilities, lack of health workers, inadequate commodities and equipment, and so on and so forth. But underlying all this, we do recognize that the issue is the system, the challenges that are really at the health system level, and that is the root cause of most of the problems when we try to deliver programs. So for our maternal child health, we take a health system strengthening approach, which really focuses on the WHO 6 building blocks to see how we can strengthen the system spanning all the way from the community to the facility, so that we're able to deliver impactful programs. We deliver programs for immunization, reproductive health and maternal health and childhood illnesses. And of course, hepatitis, though it doesn't come out as a big picture item, is part of our prevention of mother-to-child transmission work, where now we're focusing on triple elimination, and we're thinking much about eliminating vertical transmission of bloodborne diseases like HIV, syphilis, as well as hepatitis B. So that's where our two streams of work interface. So in terms of our work, we do work at the policy level. We also do work at the service delivery level, making sure that we build the capacities for an integrated delivery of packages that are integrated on the maternal child health platform, because that is the platform that we care much about. But we also are very tuned into the fact that if we don't engage the communities, we're not going to get there. So our continuum is right from the community level, where we engage communities for demand creation. We also engage communities for delivery of services. And then it spans all the way to the primary healthcare level, which is where we put a lot of emphasis, because we know most mothers and children, that's where they will access services. And then strengthening referrals to the secondary and tertiary level. We work in partnerships. I heard you talk about partnerships with the Global Fund. We work in partnerships with PEPFAR to really increase the financing for our streams of work, and also to ensure that we have essential commodities for the three conditions that we're interested in for prevention of mother-to-child transmission. So we're focusing on diagnostics, we're focusing on antimicrobial drugs, and also other relevant commodities, and ensuring that the supply chain is robust and strong, so that we're able to deliver services that are uninterrupted. Now, in terms of this prevention of mother-to-child transmission work, and I'm soon going to hand over to the next speaker, so far, we've had a number of countries that have been validated as having eliminated HIV and syphilis, so the dual conditions. But now we're pushing, we have a big push to make it so that countries think of elimination of the three conditions, so HIV, syphilis, as well as hepatitis B. And there's a lot of traction on this. Countries have signed up on this, and the recently released global health strategies, health sector strategies for HIV, viral hepatitis, and sexually transmitted diseases that was just released at the Global Health Assembly, will really help us. The World Health Assembly will really help us to gain momentum in this space. So in a nutshell, just to frame the conversation so far, that is what we do as UNICEF. It's all about maternal child health. It's all about the maternal child health platform, strengthening that from community to facility, and really focusing in the context of our conversation today on the triple elimination of vertical transmission of mother to child. Over to you for further conversation. Thank you.
So much, Dorothy. I think so much that you talked about the work that you do around mother and child transmission is exactly the same as the discussions that we have in our PMTCT session. Maybe you saw yesterday. So I think there's some amazing synergies there. I do have a follow-up question, but I'm going to save it for the next round. So let's go straight to Dr. Castelli from the Ministry of Health in Argentina. Dr. Castelli.
Buenos días, buenas tardes. Bueno, en primer lugar, quiero agradecer la invitación a esta importante reunión a nivel mundial para tratar las hepatitis en líneas generales, pero también otras estrategias sanitarias orientadas y centradas en el enfoque de pacientes. Voy a compartir mi presentación. Espero que la puedan ver. En primer lugar, Argentina tiene una larga trayectoria en materia de hepatitis virales. El país ha alcanzado importantes objetivos, tanto sea para la donación de sangre segura o la implementación de un calendario de vacunación efectivo en las hepatitis, como así también un programa con un amplio impacto en el tratamiento de estas enfermedades, particularmente con el uso de medicaciones pangenotípicas para hepatitis C. En ese contexto, el Ministerio de Salud de la Nación estableció un programa integral para la eliminación de estas enfermedades con vista a las metas de control y erradicación trazadas para 2030. Conforme al avance logrado en la última década, este año en particular, en 2022, se estableció un marco estratégico con eje en la simplificación de diagnóstico y el tratamiento y basándose en 3 líneas estratégicas. La promoción al acceso y simplificación de diagnóstico, la promoción al acceso oportuno y simplificación de tratamiento, y el fortalecimiento de las estrategias de promoción y prevención de las hepatitis virales. En ese sentido, estas estrategias se implementan a través de diferentes líneas, como puede ser la estrategia de un paso, conocido en nuestro país como test reflejo, la innovación de proyectos como son la incorporación de tarjetas de separación de plasma y el testeo de hepatitis C en poblaciones de alto riesgo, como son las prisiones y las personas en hemodiálisis crónica. En el marco de promover el tratamiento amplificado, se llevan adelante capacitaciones hacia los equipos de salud del primer nivel de atención, a fin de avanzar hacia un mayor acceso en el diagnóstico y en el tratamiento de toda la población. La situación epidemiológica en nuestro país en relación a hepatitis C nos muestra que desde el año 2010 al 2015 hemos tenido un progresivo incremento en la tasa de casos por habitantes, con una media de casos de 421 casos por año, con un rango entre 323 y 641 casos. En los últimos años, la tasa se encontró alrededor de 1% por cada 100.000 habitantes, con excepción de lo ocurrido en el año 2020, en donde tenemos una disminución de las tasas a 0,7, pero entendemos que esto puede estar vinculado al escenario dado por la pandemia de COVID-19. En los casos de hepatitis C observamos un comportamiento similar, donde probablemente el mayor acceso al diagnóstico y sobre todo las posibilidades de tratamiento impactaron de forma positiva en una mayor detección, que es la que se observa entre el periodo de 2010 a 2015 y que se mantiene estable particularmente en el grupo de edad de los 30 a los 45 años. En ese sentido, y en relación a lo que podemos observar del análisis de los años previos, del total de la población estimada con hepatitis C, estimamos que un 50% de estas personas conocen y acceden a su diagnóstico, que de ellos el 45% accede al sistema de salud, un 25% de estas personas logramos confirmar el diagnóstico, solo un 10% logran tener una evaluación adecuada del estado de avance de su enfermedad. Y un 5% son los que acceden a una prescripción de antivirales para el tratamiento, alcanzando una cura del 4.5% del total. Entonces, ¿cómo podemos cambiar esta situación? Debemos incrementar el número de personas que se diagnostican, simplificar la estrategia de diagnóstico y asegurar una mayor equidad en el acceso de tratamientos antivirales. Por ello que se han llevado adelante estrategias como la simplificación del diagnóstico y el acceso al tratamiento de hepatitis C a través del test reflejo, o para simplificarlo, para poder compartirlo con ustedes, lo que sería diagnóstico y tratamiento en un paso. ¿Qué implica esto? Tradicionalmente en nuestro país, una persona que hace su primera consulta en función de una posible hepatitis C, tiene que realizar un laboratorio para hepatitis C, confirmar este laboratorio, luego hacer la carga viral y la genotipificación, una tercera consulta para que tenga una devolución y la prescripción del tratamiento, y finalmente poder acceder al mismo. Todas estas etapas lo que tienen riesgo es de tener una pérdida de seguimiento en cada una de las instancias. Y en ese sentido hemos reducido con la estrategia del test de reflejo o con la estrategia de un paso, en que en la primera consulta se pueda llevar adelante la toma de muestras para determinado que si hay una hepatitis C, a través de un análisis serológico, poder en un segundo tubo de muestra, poder hacer la carga viral y la genotipificación. Con lo cual, aquellos pacientes diagnosticados bajo esta estrategia, en la segunda consulta con el equipo de salud puede tener la devolución en relación al diagnóstico y puede tener la indicación para el inicio del tratamiento. Y adicionalmente, en el marco de la utilización de tratamientos pangenotípicos, poder incluso solamente realizar los estudios de genotipificación con orientación de vigilancia epidemiológica. Es decir, para resumir, en una simple muestra se colocan 2 muestras de sangre en tubos separados, uno para la realización de la detección de anticuerpos para hepatitis C, y si este resulta positivo, en el segundo tubo poder realizar la detección, cuantificación y carga viral de C. Con lo cual, en la segunda visita, en caso de ser positivo, el equipo de salud puede indicar en forma inmediata el tratamiento en estos pacientes, y esto, en el trabajo realizado en un estudio piloto, permitió que sobre 2.335 pedidos de hepatitis C ya se han detectado 87 casos en los cuales fue detectable una carga viral para C en el 70% de ellos, y permitió tener un tiempo promedio entre la primera consulta y el inicio del tratamiento de solo 37 días. Bueno, tomando esta iniciativa, llevamos adelante, es un plan nacional para microeliminación en hepatitis C en instituciones que llevan adelante diálisis crónica en nuestro país. O sea que claramente la prevalencia de esta enfermedad en este grupo de población es sustantivamente mayor. Y a fin de poder hacer los tratamientos de una forma adecuada y garantizar el acceso, aquellas personas que son detectadas en el marco de diálisis crónica, si tienen un APRI mayor a 145, es la única situación en la cual se plantea una derivación, un equipo especializado, pero en caso de que tengan un APRI menor, se llevan adelante capacitaciones con el equipo de salud de cada una de las instituciones que hacen hemodiálisis para permitir el tratamiento en estos centros y garantizar un acceso mucho más rápido a cada uno de estos pacientes, con el impacto que esto tiene en la salud de poblaciones de alto riesgo y que además están en el marco de un posible trasplante en su futuro próximo. Con una orientación similar, en una estrategia orientada a poblaciones de alto riesgo, se llevan adelante el diagnóstico de hepatitis virales en personas privadas de la libertad de nuestro país, con la utilización de test rápidos, tanto de hepatitis C como hepatitis B, garantizando el acceso al diagnóstico tanto en cárceles federales como en cárceles provinciales, y permitiendo que se pueda llevar adelante la genotipificación y la determinación a través de equipos como por ejemplo el GeneXpert, de manera tal de que estas poblaciones también accedan rápidamente al tratamiento pangenotípico en caso de ser necesario. La evolución de la enfermedad y de la mortalidad por estas enfermedades en nuestro país, vemos que ha tenido un sustantivo descenso a partir de la introducción de los antivirales de acción directa, reduciendo las tasas por cada 100.000 habitantes de 0,3 a casi la mitad, a 0,16 en el caso de hepatitis C, y manteniéndose por debajo de 0,5 en los últimos años las tasas de mortalidad por hepatitis B. Argentina dispone en su plan nacional de drogas pangenotípicas para el tratamiento de hepatitis C, y estas indicaciones se alinean a los tratamientos tanto de las recomendaciones regionales como de las recomendaciones internacionales, asegurándose un rápido acceso al tratamiento a todos los pacientes en donde se determina un diagnóstico y se puede hacer una evaluación en relación a la carga viral de la enfermedad. De esta manera hemos llevado adelante, tanto en el año 2020 como en el año 2021, tratamientos a lo largo de todo nuestro país, aumentando el número de tratamientos de 528 tratamientos en 528 para el 2020 a 987 tratamientos en el año 2021. En conclusión, los ejes centrales de esta estrategia se basan en la simplificación y diagnóstico y tratamiento, la estrategia de un paso y la microeliminación en poblaciones claves, con el objetivo de garantizar un acceso oportuno al tratamiento de las mismas, la simplificación de tratamientos basados en GP y en otros esquemas de agentes antivirales de acción directa, la adopción de una vacunación y screening universal para la población, y como desafíos tenemos que seguir avanzando en la descentralización del diagnóstico y el tratamiento para permitir que el primer nivel de atención pueda ofrecer las oportunidades de diagnóstico a todas las personas que puedan ser evaluadas, y de esta manera también fortalecer la información del sistema para poder hacer que la detección cada vez sea más oportuna y el tratamiento sea en un momento adecuado, evitando la progresión de la enfermedad, curando a estas personas y disminuyendo los efectos que producen el avance de una enfermedad crónica de estas características. Muchas gracias.
Thank you so much, Dr. Castelli. It's great to see the simplification and the bringing the services closer to communities. I mean, those are all, really great things that the Alliance hold very dear to our hearts. So we've had kind of a global, well, maybe just two things before. For people that are in the room, you can access translation, simultaneous translation, if you're logged onto the platform through your headset. And number two, please put your questions in the Q&A box if you are on the platform, rather than the discussion checks. Then we'll be able to find them easier. So we've had global level, we've now had national level. Now we're going to go right down to the local level and hand over to Juan and hear about the great work that you guys do in Thailand to serve the needs of your communities. Thank you.
Yeah, thank you, Carrie, and I am from Vietnam.
What did I say?
You said Thailand.
Oh my God.
We are just 1 hour flying from each other.
There had to be something that I got wrong, so that was it. I don't have to worry about that.
So next time we meet in Thailand. It's great to be here, and thank you for inviting me. I am the director of local NGOs in Vietnam called the Center for Supporting Community Initiative, SCDI. We work with the marginalized and vulnerable population. That is our focus, and we try to work with the people-centered approach. That means focus on the population and try to address as much as possible their needs. I'm a doctor by training, medical doctor by training, so very often we use health as an entry point to work with the population. So we work a lot with people who use drugs and people living with HIV, sex worker, the LGBTQI community, the homeless people, people living in slum, indigenous ethnic minority community. So just like at first we work with them on HIV, and then we realized that now with the great HIV program, people don't die of HIV anymore, but they die of hepatitis. So hepatitis B, hepatitis C, cancer due to hepatitis. So the need for intervention for hepatitis become increasingly important if we are true to our mantra is people center. So we start to work on hepatitis. And just to share with you some of the example, we was working on a project trying to end HIV transmission among people who inject drug. And together with researchers from the US and France, we came to the conclusion that among this population in a city where we work, there is no more transmission among people who inject drug for HIV. So for 3 years in a row, we monitor on a cohort of like thousands of people, no new transmission. So we can say that we managed to end the transmission of HIV. But for hepatitis C, like more than 60% of the population of people who inject drug in that cohort are hepatitis C positive. Hepatitis is the second cause of death among that cohort. And when we look at the new infection, the incident, it is 12 per 100 person year. For HIV is 0. For hepatitis C, it's 12%. Can you imagine? So it's really a problem. So we work with the people to start a micro elimination project that we treat everyone, all the people who inject drug in that city who are eligible to hepatitis C treatment. So we managed to treat 1,200 people for hepatitis C. But one of the issues here is that it's not only about the treatment availability. It's about supporting, engaging with the community so that they come for treatment, they take up the treatment, they adhere to treatment for 12 weeks of treatment, they come for evaluation tests and so on. So, and we was able to do so, a high success rate, 97% of the people who are treated was cured. We prepared the second line treatment. We didn't need to use second line treatment because everybody responds so well for the first line treatment. So it's a huge success. And I think, and everybody, the clinical team, the management team, the local authority believe that we could get that result because of the high level of engagement of the community. So the community-based organization work with the population and then to engage them in treatment. So just to say that our approach is a people-centered approach, working with the community based on their need and engage with the community all the way through the design of the project to every step. So we are going to do an evaluation like 3 years after that cohort, the project, to see if there's a reinfection or what is the long-term, the sustainability of the result. But we are very confident because we don't see people die of Hep C in that cohort anymore. But we'll share result when it come out. But just to say that, yeah, people-centered, community-based, based on the need of people and with the engagement of people. It works. Yeah.
Excellent. Wow, that's amazing. And yeah, exactly. Just goes to show that when you apply those values and those principles, the results can be really staggering. So thank you so much. Thank you. So maybe, Javier, we could go over to you next, and you can talk about a little bit about your experience and then the kind of work that you do as a part on the community's delegation of the Global Fund and UHC 2030 on steering committee.
Yeah, thank you. Thank you for the invitation to this summit. We work a lot in co-infection of HIV and hepatitis in Argentina and many other Latin American countries. And then we have treatment, and I have been learning the last 2 days a lot. Thank you for the invitation. And I think that my role in the Global Fund, I am a board member of the community's delegation of people living with HIV and affected by TB and malaria. And we also engage key populations on the vulnerable populations on the 3 diseases. And also have the privilege to work with some people here in the stage in the community engagement mechanism, civil society engagement mechanism, who is a constituency on the Partnership for Universal Health Coverage 2030. And I think that they are one thing in common. We are constituencies of communities and people living with the diseases across the world, that have the opportunity to come to regional and global health institutions and governance mechanism to bring the voices and discuss what is relevant for our community. As you know, we are in a hunting season, as I call. Many global health institutions are replenishing their resources, and there is not much. There are the usual suspects that very gently support the response of the Global Fund and other global health institutions. But this is also an opportunity because there is a turning point. The 3 key organizations around the world have launched or are about to launch, in the case of the Global Fund, their global strategy. The Global Fund strategies will be hopefully approved by the end of the year, but the UNAIDS launched in the high-level meeting the Global AIDS strategy, and WHO just launched the Global Health strategy. So for community, people which we serve and work at the global level governance, is so important to find alignment across, for example, in this case, the 3 diseases, synergies, not duplication, not going to the donor to ask for the same kind of interventions, and making sure that communities, people living with the diseases are represented at all levels, global steering committees or board, etc., at regional level and in country level. That we have an open and honest dialogue, what we call technical partners, for example, in the Global Fund and UHC 2030 WHO, since, as well as UNAIDS, Stop TB, Rollback Malaria, etc. So, and I think that the turning point, because we are not only having lack of resources, we learn already the lesson that we need to integrate services. Often the Global Fund is criticized by looking into 3 diseases, AIDS, TB, and malaria, and was created 20 years ago for a reason. But now 1/3 of the money we plan, or the minimum money we plan to mobilize, 18 billion, by the end of the replenishment, 6 billion will be allocated for resource, what we call resilient system for health, which is health system. So this is a very, very important development, and we need to watchdog or be quite vigilant as civil society and communities how this will be implemented if we get all this money. And I think that, I think that whatever we manage to show the added value of the participation of communities at the ground level, we will be able to allocate more and more money for community system strengthening. And when I say community system strengthening, we all agree, and there is amazing examples in the program of this summit around hepatitis and HIV, etc., around how people living with the diseases and communities, and vulnerable communities, could lead on providing community health services, to peer approach, etc. But it's as important as that to have civil society and communities doing advocacy, policy, watchdog our governments, and go by and say, you know what, guys, there is something that we can optimize here. There is something that is not working in this province, etc. And governments need to continue learning and scaling up the meaningful involvement of communities. And to give you, and to close my first intervention here, to give you an example, communities, people living with HIV in Argentina just pushed for 4 years a law, and nothing to do with Dr. Castillo or the government. That was the legislative body of Argentina. And finally, we passed the new law for comprehensive response to HIV after, I don't know how much decades with an old law. So this law is also looking into integration. So I think that that's an example where the current government, the current administration, and civil society and community push more proactive law. Of course, in most of our countries, HIV, hepatitis, etc., it's been overshadowed by stigma, discrimination, criminalization, etc. So new law reforms in many of our countries is a main priority. I stop there. Sorry to take too much time.
No, that's brilliant. It's so important. So maybe we'll just go straight to Luis, and then we can come back and discuss some of these points later. So Luis, obviously you're an amazing advocate, and the services that GET provide, is really a flagship of what we're really talking about. But you're also someone who's living with HIV and someone who's been cured of HCV. So it'd be great to hear your experience as someone, that was treated for these conditions and the importance of integration and the work of GATT, please.
Thank you for the invitation. I was looking yesterday back to these last 25, 26 years and the progress that was made and what we still need to go to find the right path to elimination of viral hepatitis as a public health threat, etc. And we do have the means. I would like to highlight that sometimes the burden in the advocates, activists, expert patients, etc., is very big. And I remember that I was injecting drugs in the late 70s. It was very chic, trendy, etc. And I think that it was there my hepatitis C and later by sexual contact the HIV. I was only diagnosed in '96 with full-blown AIDS and dying, let's put it this way. Of course, there was also HCV diagnostic, and it was the least of my concerns at the moment because I had 2 CD4s, etc. And the first big thank to the activism was that in Vancouver, '96, July, there was presented the triple combination and the protease inhibitors. And I was diagnosed 2 September, and I had the triple combination because the advocates from Portugal made a huge work to make the government sign for the reimbursement of the new HIV drugs. And I really think that this saved my life at the time. So when I got better, I had this, because I had a training as a biochemist in Paris 40 years ago, more than 40 years ago. And they were always saying, well, you know something about science, etc. You can help us in looking at the clinical trials, the input to the pharmaceutical companies, etc. And I thought that I need to give back what I did receive from my advocates and activists. 2003, HIV was okay, but I was very sick with hepatitis C. And namely in Portugal, Spain, Italy, etc., the rate of co-infection, HIV, hepatitis C was very, very high, 40% in Portugal. So we had that urgency also from the HIV field of we need to do something about viral hepatitis because we are not dying anymore of HIV, but we will die of the disease caused by HIV. And in 2003, I had the most horrifying experience with the medieval treatment that existed at the time. It was on the 21st century already, and I was in hospital for more or less 2 months. And on that, it was a certain personal commitment that we need new drugs, we need new approach, and we need to invest in research and development. And so then we created with co-infection, with TAG from the United States, a meeting that put together companies, researchers, the community, etc., to not let behind the co-infected at the time. And I remember a moment when, because the HIV people used to be the stars and be on the stage, etc. And of course the people from hepatitis wanted and needed and deserved to get the stage on that moment. And so I was one of the go-betweens, the two communities, saying, look, friends of HIV, I'm with problems with my hepatitis C, so please don't make me choose between the two challenges. And in 2008, we created in Brussels with activists from the United States, Canada, and Europe, the European Community, the HCV Community Advisory Board, that had a mission of foster the development of interferon-free cures for hepatitis C. And for 5 years, probably, I was traveling almost monthly to the United States to meet. We were a group of 20 only, though very progressed. And I remember when we saw the first results of the study between 7977, that was the first name of sofosbuvir with daclatazvir, 10 people that were non-responders, all cured, and we said, we cannot go behind, and we need to go there. Then we knew that the scientific problem was solved. It was access. And also another thing that sometimes I was not in agreement with other colleagues, it was very clear for us that looked at the drug development, that the first generation with boceprevir, telaprevir should live very shortly and be replaced. And even the second generation of better drugs, but together with interferon, cimeprevir, others, we needed to overcome that. And this was a huge fight because the companies want to make the money on the investment of boceprevir, telaprevir, etc. And then I concentrate very much in my country, and we led advocacy, activism, protest, etc., evidence to say we need to lower the prices and give access to everyone. This is an infection, we have a cure, it's very simple, everybody needs to be cured. Of course, per $1,000 a pill, it was not possible for Portugal, though we are not very, very poor, but it was absolutely not possible. So this was the way, and then it was the fight that still goes on to not let the most vulnerable behind. The prisons, the people injecting drugs, sex workers, LGBTI, etc. And make an effort on literacy that I think that it's the community that can help better to do these literacy efforts and that's why we open services that do decentralized one-stop shop or one-stop shop. I don't remember the name, is something from Switzerland. That where they get everything. We have a center for mainly for people using drugs and homeless, and we have another one for sex workers and trans people. And the third is mainly for MSM that now are the most attained by HIV. Shortly, these need to work based on evidence, pushing innovation, true innovation, not fake innovation, convincing the governments and the politicians, doing services for our community. It's quite difficult based on human rights, etc. Portugal has good legislations, and it was probably one of the first countries in early February 2015 to approve that everybody would be eligible for treatment after a huge negotiation with Gilead to drop the prices. Nowadays, we see the need to invest in, that's why I also accepted to be a chief co-chair, though I'm very retired, because we have a problem with the cancers caused by virus. It's, of course, hepatitis B, of course, hepatitis C, but there are other viruses that also cause cancers. And the investment in the fight against cancer needs to be also a fight to prevent and treat viral hepatitis and other viroses. Today, I'm working more in hepatitis B because in my country we have a good vaccination program since very early. We have a very good national vaccination program, but we are becoming a country of migration. And we have many migrants coming from endemic regions, and we need to be very attentive. It is one of the diseases that is more subdiagnosed in Portugal, so it's something that we are working on, putting also the cure in one side, even if it's functional, for hepatitis B on the agenda, because it's near 300 million people affected. So with great enthusiasm, still working on viral hepatitis. Thank you.
Great, thank you. Yeah, you're certainly not retired, Luis, from any normal person's standard, for sure. Thank you so much. So that really segues us very nicely to you, Carrie, and the UICC. It'd be great to, again, because this is maybe a first time we've had you at the summit, to talk a little bit about the UICC and the kind of synergies with liver cancer and how we can work together on addressing them.
Sure. Thanks you very much, Kerry. I've not said that before. The first time I've met
Yeah.
another Kerry in my life, I think. So it's quite extraordinary being on the panel with two Kerrys. Yeah, so actually it was a great segue. So the UICC is the Union for International Cancer Control. It's based in Geneva. It's a Swiss non-government organization. It's in formal relations with the World Health Organization, but we also work with the International Atomic Energy Agency and the International Agency of Research on Cancer. We have 1,200 cancer organizations as our members around the world, which could be patient groups, it can be ministers of health, it could be the large international bodies like the American Society of Clinical Oncology, or it could be all the cancer leagues and the cancer societies country by country. So although UICC in Geneva does not have a specific liver program or a project, many of our members around the world are clearly engaged in liver cancer. That would be Cancer Research UK or the American Cancer Society, etc., etc. In fact, UICC only runs 2 specific disease projects, one on breast cancer and one on cervical cancer. But the rest of our work is absolutely critical, as you described it, to the integration issue of how do we address all cancers through the appropriate channels and the platforms that we have. So let me just say that liver cancer is, I think, the 3rd highest cause of death in cancer around the world, so it's important, very important. It's linked very closely to hepatitis B, with over half the cases caused by, as you described earlier, the virus. And so it's important that we as UICC make it clear that the prevention of liver cancer, because to be fair, in most parts of the world, liver cancer is presented at stage 3 and 4, and the survival rates are extremely low, akin to lung cancer with today's technology. So prevention is absolutely critical. Now, with regard to the work that we do on prevention, we take our lead from the World Health Organization. So the WHO's lead to us is Appendix 3 of the NCD Action Plan. And in that Appendix 3, not very well titled, but Appendix 3, there is the full list. Have I lost the sound? Can you still hear me?
Yeah, we can hear you.
Yeah, the full list of recommendations from WHO for interventions on various non-communicable diseases, but also on cancer itself. And in there is a recommendation that all countries should have hepatitis B immunization. So therefore, on that basis, UICC, through the work that we do, we recommend that to all national governments when they're constructing their cancer plans. Now, the cancer plans, the way we get involved in cancer plans is that we have established an international cancer control partnership. Now, that international cancer control partnership has been established for 10 years this year, And it works with governments around the world to ensure that their national plan for cancer includes all the various aspects which are recommended by WHO and other specific issues which are peculiar to that particular country. Okay, so the epidemiology of that country might dictate there should be something else included or emphasized within the National Cancer Control Plan. So we do stress in our advice and guidance to governments around the world that they do have vaccination programs in place. Now, we also are guided by a document called the World Cancer Declaration, which was first written in 2009 and set out a number of targets. I think it was about 10 or 11 targets, which we felt are areas where countries should work on to, over time, control their cancer burden and to be more successful treating those patients who develop cancer in their lifetime. So that was refreshed in around 2014, reflecting the new NCD targets agreed by the WHO. And we took those targets through to 2025 because that's when the NCD targets are due to be reviewed at the United Nations in New York. We have reviewed progress against those targets in 2019. And one of the items we looked at was the degree to which the Hep B jabs are being provided to babies. And we were pleased to see an increase in the numbers. And I've got the numbers here, that the coverage of 1-year-old, below 1-year-olds went from 70% in 2010 to 85% in 2019. Which is good news. And we know this is a long game. It takes a long time. But we have a similar approach to the issue of the elimination of cervical cancer, another initiative of WHO, which we helped to construct. And that initiative, again, looks for a very high penetration of vaccinations and also early detection and treatment availability over time in order to eliminate that cancer. So a lot of the work that we've been doing with WHO, reinforcing their messages, working with national governments and our own members, is to advocate for the actions required to reduce the burden of cancer in the future. And much of that is on prevention. Now, if we add on at the moment the growing obesity crisis, and we add on the issues of alcohol use around the world, then I'm afraid liver cancer is becoming more and more of an issue for UICC and its members. And we were delighted at the World Health Assembly this year that both obesity and alcohol featured within the agenda for NCDs, and it received our full support. So although, I'll go back to my beginning, although we don't have anything specifically on liver cancer, a lot of the work that we put in place creates the framework or the architecture for us to work together with those who are committed to the issue of hepatitis to push it through the cancer agenda at a national level. So I hope that was a sufficient oversight of what we do.
That was brilliant. Thank you. Thank you so much. We have lots of questions in the Q&A. If people still do have questions, please do put them in, and we'll try to get to as many as possible. So I think I'm going to go straight. And if anyone in the room would like to ask a question, just kind of raise your hand or move your nameplate, and someone will come with a roving mic. But maybe we can start with a question for Dorothy from the platform. I just need to find it. I have to do. Yep. I'm not good at doing more than one thing at a time. So, so at Dorothy, thank you for your words of introduction. Are there any experiences or gaps seen from UNICEF on HIV elimination of mother-to-child transmission that we can learn from as we start hepatitis B elimination, mother-to-child transmission in our countries?
Yeah, thanks for that. I mean, and thanks to the panel, I've really learned so much from everybody. The question is a tricky one because there are lots of gaps. Our biggest gap is around interventions around delivery. So for the hepatitis B, we really aim to give the first vaccine to infants at birth. And currently, less than 50% of women don't deliver within health facilities. So this delivery of the birth dose is one of our biggest challenges for HIV as well as for hepatitis B. And we're trying to work on that, and that's an area that we need to see how to better collaborate with traditional birth attendants, not for service delivery, but to ensure that babies get this birth dose as an intervention. the birth dose issue is also very pertinent for HIV, where we want to diagnose any infant who has been exposed to HIV early enough and have interventions. So that's an intersection point. The other gap that we're challenged with is on the diagnostics, and I was really very interested in the work that Dr. Castelli is talking about better diagnostics, because when women come in, we would really want to be able to give them diagnostics that are integrated. So right now we have dual test kits for syphilis and HIV, but we don't have point of care diagnostics for the hepatitis B. And that's a gap and something that we're really advocating for, to see how we can strengthen or have the tests available at the lowest level. So those are my immediate responses for that. And the final thing I also wanted to say, based on the Carrie number 2, the one who just talked about from the atomic from the atomic agency. You know, this linking cancer and hepatitis B is not done very well. So that people are here and they see this liver cancer and there's a lot of angst about it, but people don't really make the link with the fact that you could actually prevent a lot of this if you were intervening very early during childhood, during birth and delivery. And that's a message that we really want to work with the communities with. And that's another area where HIV hepatitis can intersect. That would be my long-winded answer to that question. Thank you.
That's great. Thank you so much. The next question is for Dr. Castelli. And the question is, and it's regarding to asking about maternal and child transmission in Argentina, and do you include them in your national strategies?
Sí, nosotros incluimos en nuestras estrategias nacionales la estrategia de la eliminación, transmisión materno-infantil, de sífilis, de HIV, de hepatitis B. Estamos haciendo hepatitis C en algunos pilotos y de Chagas, enfermedad de Chagas. Es una estrategia que se conoce en nuestra región como ETMI Plus, y en relación a la que estaba contando recién Dorothy, entendemos que la estrategia tiene que basarse en el acceso al diagnóstico a través de métodos rápidos y en garantizar rápidamente las intervenciones para disminuir la transmisión vertical. Hay un problema regional, nacional y creo que es internacional, que tenemos una epidemia oculta de sífilis. Y en relación a lo que decía recién Dorothy sobre hepatitis B, creo que tenemos que mejorar nuestros sistemas de información, la calidad de nuestros sistemas de información, para tener una real dimensión del impacto que tienen estas enfermedades, tanto en la transmisión vertical, en la afección de niños pequeños, pero también en su relación con cáncer, por ejemplo, con el hepatocarcinoma, o las causas de mortalidad vinculadas a infecciones crónicas como el HIV, como la hepatitis B, porque muchas veces no se hace un vínculo adecuado y esto no le da una real dimensión sanitaria.
Excellent. Thank you. Thank you so much. Next, we have a question for Juan, and I think we're staying on a related topic to hepatitis B. It says, Dr. Juan, given the high prevalence of hepatitis B in Vietnam, can you share if you are also working or plan to work on hepatitis B as well?
Yeah, we have been working on hepatitis B, not as directly as hepatitis C, but in a more system approach. So hepatitis B diagnosis and treatment is covered by our social health insurance, so it's quite available, and immunization for hepatitis B is good in Vietnam for the birth dose and so on. But of course, we have a high prevalence of hepatitis B among the adult before we have that birth dose immunization like 20 years ago. But the treatment, diagnosis and treatment is available and covered by our social health insurance. Now, the issue is, number one, for the community to be aware of the hepatitis B issue, because in particularly marginalized community, people don't necessarily care much until they are very sick. So screening of hepatitis B, make sure that people know about it. And the second is that to make sure that people have access to social health insurance. Because if you don't have access, if you go to the private clinic, the cost can be high. And in particularly for Hep B treatment, you need to take it forever. So make sure that it have a high coverage, that you are covered by social health insurance, and you continue to be covered, because the premium is paid for 1 year, and if you don't continue, you drop out, and if you don't have a continuous coverage premium, you will lose the privilege. So it's very important that people are on social health insurance and have a continue to be on social health insurance. So we work on that matter, make sure that the population that we are working with are aware of hepatitis B, aware of social health insurance, being engaged, being involved in social health insurance. There are different obstacles for people to get to social insurance. Do you have an ID paper or not? Do you have money to pay for it or not? Or to have money to pay on time that says no discontinuation, you know how to use it, which paper to use, where to go, etc. So we are working on that. But I think it's now listening to Carrie about the cancer and so on. I think that is another message that we can do in our campaign, the communication effort about hepatitis B. We try. I have to admit that we focus a lot on hepatitis C because of the treatment become available, but for hepatitis B, we need to increase our efforts so that people are more active on that. But yes, not very well, but we've been working on that. Yeah.
Well, perhaps I could add, I think that most cancer societies or cancer leagues country by country would welcome an approach from the hepatitis community to reinforce the messages, because we are going through excuse me, a period of time with a lot of vaccine hesitation around even HPV vaccinations. And I think if there's a joint effort country by country to press for the value of vaccines because of the long-term benefits to society of avoiding other illnesses and other diseases, then hopefully that would engage governments to see it as a strategic investment over a longer time. So I would encourage all hepatitis groups, patient groups, to talk to their local cancer society or cancer league to see if there is opportunity to press, for example, that it is included in the National Cancer Control Plan. I mean, that's an obvious avenue to get a cervical cancer HPV and liver cancer hepatitis B vaccination programs in place.
Just a little bit more on this. Since I am listening to Carrie, I was thinking that because there are people who fall through crack for immunization, like a birth dose, because the people who was delivered at home, like Dorothy mentioned, and some others. So that happened particularly among the vulnerable and marginalized population. So as a strategy to prevent cancer, liver cancer among them, maybe we will need to develop the program to screen the people who may not get the birth dose, may not get Hep B immunization in their life, and to give them the immunization if they are eligible. So that could be a program that I'm thinking that may be helpful. If anybody have that experience, I'd be very appreciate if you can share. Thank you.
Brilliant. Thanks. Javier?
Yeah, I think that what we are hearing here is that people living, as some people in this stage, people living with diseases or affected by diseases across the board, we need to come together, and at the country level, at the regional, and at the global level. And that's probably the intention of the civil society engagement mechanism of Universal Health Coverage 2030. By the way, we are open for recruiting and replenishing the advisory group. So go into UHC 2030 or the Civil Society Engagement Mechanism webpage and please apply, because we need expertise from communities and civil society working on cancer, hepatitis, and we all have careers, by the way, but another diseases, and not the usual communicable diseases, which we gain a lot of traction in the last 20 or so years. And that needs to happen at the country level. I mean, the discussion around integration, sustainability needs to happen. I mean, we are the people that needs to advocate not only for HIV, TB, and malaria. We need to advocate that at the point of care, transgender woman who is a sex worker not only get an HIV and syphilis rapid test and probably treat syphilis if it is positive, get vaccination, get prophylaxis pre-exposition for HIV, and then create a relationship on more comprehensive health that in the next visit could be screened for early diagnosis of some cancers. I mean, we have the reputation of working in silos, vertically, HIV, TB, malaria, hepatitis, cancer, etc. No, we have been advocating and pushing, even in the Global Fund boards, World Health Assemblies, etc., that we need to work together. And we have this commitment now because we realizing with COVID, number one, that there is no resilient health system. That's the bad news. And any pandemic or any diseases in our countries, whatever is a developed or developing country, poor or rich country, any disease could become a catastrophic cost for a family, right? So the issue of inequality is a cross-cutting across any health issue. And we want the things about the HIV, TB, malaria, hepatitis, community mobilization that may help other cancer also, may help other communities of people affected or living where of the diseases to mobilize. And of course, also share with them what doesn't work. We learn what doesn't work. So please, also we are recruiting for the communities delegation of the board. So try to join us because we need young people, we need new diseases advocates in the UHC partnership and in the Global Fund. Thank you.
Brilliant. Thank you so much.
Just to reinforce one thing that when we saw the first, as co-chair of Achieve, when we saw the first draft of the Europe beating cancer, there was the question of vaccination for hepatitis B, the universal coverage, etc. And very good, and we need to do it. But something that was not clear was the effort to diagnose people as soon as possible with viral hepatitis and treat them, in the case of hepatitis B, when needed. It's also prevention, and it's also cancer prevention. We see a huge decline. There are people with cancer after being cured from hepatitis C, but the decline on the after cure is immense. So reinforce that screening, support for the most vulnerable, because usually they are left behind, and some hospitals are also not places where some people like to go because they don't feel welcome. Point. So this treatment, diagnosed care and support is fundamental in our opinion to reinforce the prevention of cancer. And of course, no hesitation for vaccination. Portugal had a huge success, I must say, in vaccinating against COVID, 90% of the population or something like that. So we really need to remind that preventive vaccination. It's not the case of COVID. It's the most important public health tool that we can have.
Excellent, thank you. And I'd really like to come back to you, Carrie, as well about, we talked a lot about liver cancer, but also I think the great success for HPV vaccination and getting that on the agenda and really, pushing that forward when, I don't think that was a likely thing if you would just look at it. I know in the UK we had quite a lot of resistance for providing HPV vaccinations to young men and to other things. So it'd be great to hear about that journey for UICC around HPV and what we can learn from that in terms of promoting hepatitis B vaccinations.
Sure, and can I just reinforce just before I go on about the siloed approach, because UICC has a track record of reaching out to other communities where we have common interests. So we first established the NCD Alliance back 11 years ago, I think it was now, maybe longer than that, 12, 13 years ago. And we've been a mainstay of that, engaging other NCD groups to make sure that we work on these common risk factors, improvements in primary health care, data availability, common data collection and registries. So there's so much that we can do together which will benefit all of society. And listening to the conversation, it's probably worth saying that whilst cancer is described as a non-communicable disease, as we've just been discussing, and you've asked the question, that a significant proportion of cancers start as an infection and or a virus. So we bridge that space. We're not purely an NCD. Regard to your question about cervical cancer. So cervical cancer came on the agenda really, I would say about 3 years ago, when a series of discussions took place with actually Dr. Tedros with regard to, was there a possibility of eliminating cervical cancer? And if so, how and by when? And that prompted a lot of international specialists reviewing the potential, led by some great researchers in Australia and UICC member individuals as well. And a proposal was put forward that indeed there was an opportunity to eliminate a cancer. And that, to me, was the tagline which really engaged people, because we all know, I think we've all grown up with the big C in the background, which was going to kill you at some point. And the story of the elimination of a cancer captured the imagination as a beacon of hope for most people. And so it gained traction at WHO, national and NGO level around the world, because it could be something that we could eliminate by 2050, 2060, 2070. It depends how quickly we roll out vaccines. It depends how quickly we roll out screening and then treatment and care being available. The other advantage, I think, is concurrently with that piece of work, we've seen evidence which has allowed us to see that the vaccine has gone down from 3 doses to 1 dose recommendation now, and the price has dropped dramatically. The introduction of Gavi getting involved with this as well. So that a lot of players have become involved in the elimination story, and that's the tagline which I think has brought people together. And beneath that, there's obviously the science and the evidence on how you can actually achieve it over time. So I think you need a story like that to really get all the key partners around the table. So that would be my recommendation. If there was something in hepatitis about, if there was an elimination, or something along those lines, halving the deaths, it needs to have something which is marketable. Sadly, in the world that we live in the Twitter world, you go, what is the marketable statement on what we're trying to achieve?
Excellent. Thank you so much. Well, we just have a few minutes left, so I think we'd just like to go to kind of a round robin, just to have a final word from all of our panelists. And maybe just, we talked a lot about silos and breaking down silos and how we can work together and seeing how much we are already working together and addressing viral hepatitis, but the wider views of the communities, because we can't really achieve equity unless we really look at a whole holistic, people-centered approach. So maybe we'll just go around to have a final word about what we talked about, or maybe just a suggestion on how we really can move forward away out of the silos into the future. So I'm going to start with you, Dorothy, if that's all right. Oh, sorry, we can't hear you, Dorothy. I don't know if you're on mute or...
Yes. Sorry, I always forget to unmute. I was just saying it's really been a great panel, and my parting shots is let's do more on the maternal child health platform. There are a lot of opportunities for us to synergize there. There's already successful work that we're doing, and then we really do hope that we can make it a triple agenda, or even broader than a triple agenda. The HPV work is really also captivating my imagination. So that's a platform that if we strengthen, and I'm so glad that the Global Fund is really talking about resilient health systems. If we strengthen that platform, there's lots we can do around this agenda. Thank you.
Excellent, thank you. Dr. Castelli, please.
Creo que lo más importante es aprender de
The most important is to learn from the lessons learned from COVID. We have to think that in a global way, we need more access, more equity, and more quality of the health systems. And we have to think of these problems as global problems and the infectious diseases. We have here in the panel someone that is suffering from these diseases, and we know the success of vaccinations. For example, vaccination against hepatitis B.
Just wishing that World Hepatitis Alliance keep doing the work in a partnership with World Health Organization, that I think it's very sui generis, and it was very good that it happened this way. But really, we have a divided world between rich and poor. We have, even in the rich countries, inequity between marginalized communities and the other good citizens. So I think that we still have very much to do on elimination of hepatitis, and probably on cervical cancer, and on hepatocellular carcinoma, that it's achievable and we should do it. Sorry.
No problem. Thank you.
Well, I think that, again, I strongly believe, and people here in the stage too, that, for example, a space like the civil society engagement mechanism, which is the civil society and community constituency to the Universal Health Coverage 2030, is a place where we can come together, blow up all the silos, and try to think strategically how we can eliminate it and eradicate it, or as a public health threat, or eradicate it at all by 2030, some diseases, but also how we can continue pushing together with and pushing WHO and other UN agencies to integrate, sustain, ensure access, especially for those more vulnerable and most at risk, which we do have cross-cutting. Let's talk, as Luis says, migration. I mean, it's something across the whole world and across the whole diseases. But again, I think UHC 2030, it's a partnership with all the stakeholders, including the private sector, where we can dream to eradicate some diseases and bring together universal health coverage access for the most vulnerable, despite the disease we are focused on.
Brilliant, thank you.
Yeah, and I would like just to mention two words. One is universal health coverage, and the other one is leave no one behind. So universal health coverage is supposed, if it is true to what it meant to be, is universal, mean for everyone, and for all the condition, all the health issue that important to the population. So we need to make sure that everyone, like universal health coverage, is achieved in every country. And to Dorothy, if mother and children can be a part of universal health coverage, we would address a lot of issues. So make sure that baby are covered. The moment that he or she is born, or they are born, they are a part of UHC in the country. And the other thing is about leave no one behind. So statistic we need to look at the statistic with the critical eyes. So when it say 90% or 99% birth dose, for example, we have to ask ourselves the question, who is the 1% and who's that 5%? But also the other question is, what is the denominator? So when it say 99%, make sure that the denominator include everyone, including the refugee, the migrant, the people who are locked up, the people who are criminalized, etc. Only then that statistic makes some sense. But of course, we will not happy, we will not accept the 99%. We want it universal, so it have to be leave no one behind. And we know that the last mile is always more expensive than the first 1,000 miles, right? So people, we will cannot accept the argument that it's too expensive. Okay, we have only few people, like in Argentina, we have like few hundred cases of hepatitis B or C. It would be expensive to screen them and to treat them. But if we want to go for elimination, if we want to really leave no one behind, we need to go the last mile. So that's my thought. Thank you.
Amazing. Thank you so much.
Well, I'd like to leave this panel with two actions for me. Okay, the first one is we've got the World Cancer Congress in October the 18th to 20th in Geneva. And our partner is WHO, actually, in that. And I will go back and see within the program whether we have anything on hepatitis and liver cancer. And my promise is if there isn't, we will have something, okay? The second thing is the World Cancer Day 2023, February the 4th. I think it would be useful for us to talk about how under the banner for World Cancer Day, which is Close the Care Gap, that we feature hepatitis and liver cancer some way and cover some of the issues that you're talking about there, because there's a massive inequity issue in cancer anyway. And what you've articulated beautifully is similar to all cancers, actually, that the last 5%, the last 1%, et cetera, reaching out to to rural communities, et cetera. So I think it would be worth having a conversation how we integrate you into World Cancer Day. World Cancer Day trends on Twitter for 24 hours, thousands of press coverage, TV news. There will be opportunities to raise the issues that you've so beautifully described this afternoon. Okay?
Great. Well, thank you so much. I mean, amazing next steps. And I think this is the end of this session, but hopefully it's going to be the beginning of a lot more collaboration and thinking about how we can work together and really move forward across health systems. So I'd just like to say thank you to my magnificent panel. Thank you so much. I've learned so much today. And just to remind everyone that the next session are parallel sessions, and you can choose from, you can continue the conversation about hepatitis and liver cancer. You can also join Fighting Stigma and Discrimination and Hepatitis and Integration within Health Systems. So thank you all very much, and we'll see you very soon. Thank you.